Good afternoon, everyone, and welcome to our ARCS Atlanta Virtual Education Program with Dr. Allison Chamberlain. We'll be together for about a half an hour this afternoon, which I know will be fascinating. And if you have any questions, you can type them in the chat, or we will be able to unmute ourselves at the end of the presentation. So let's begin. There are times when we are fortunate to have the right people in the right place at the right time. This is the case with Dr. Allison Chamberlain. Dr. Chamberlain is an infectious disease epidemiologist and assistant professor of epidemiology at the Rollins School of Public Health at Emory. She is also working professionally with the Fulton County Board of Health. Her dual role is invaluable during this pandemic. She is what they call a Pracademic, which means that she is able to use her research as an academic in her professional work with the Board of Health. Dr. Chamberlain has a background in biodefense policy, public health preparedness, and vaccine promotion. She directs the Emory Center for Public Health Preparedness and Research and the Emory COVID-19 Collaborative. The mission of this collaborative is to put Rollins faculty, staff, and students into the service of public health partners. Who are working to combat the COVID-19 pandemic in Georgia. Thanks to the efforts of Catherine Graves and Susie Wasserman, we are fortunate to have Dr. Chamberlain with us today to update us on Georgia's COVID-19 response, the work of the Fulton County Board of Health, and what it is like to be a Pracademic during a pandemic. It is my great pleasure to introduce Dr. Allison Chamberlain. Dr. Chamberlain.
Thank you so much, Leslie, and thanks to all of you for inviting me here today. I really appreciate it, and I love talking about the types of things that the Rollins School of Public Health has gotten involved in since, my goodness, about a year ago now, with respect to noticing, preparing for, responding to the COVID-19 pandemic. It has been a whirlwind for everyone, but inside of the the discipline of epidemiology, it has been a remarkable time to live through. And as Leslie said, I do have a background in public health preparedness and vaccine promotion, and had started working with the Fulton County Board of Health back in 2017. So prior to the pandemic, just wanting to get experience working at a state or local level. I had never done that before. I had, my background had largely been in Washington, D.C. at sort of policy level type opportunities, worked at the NIH for a little bit, National Institutes of Health, and been in academia since then. But I had always wanted to, get some exposure to what it's like at the ground level. And so having had this background in public health preparedness and vaccine promotion, and then coupled with the fact that I was sitting inside of a health department when the pandemic arose, it really was sort of the stars kind of aligned with respect to my various backgrounds and experiences to be able to be situated in this unique position between the Rollins School of Public Health and our state and local public health department partners right now. So with that said, I wanted to spend some time today sort of introducing you to the work that we're doing under the Emory COVID-19 Response Collaborative, while also peppering in some data with respect to the COVID-19 pandemic here in Georgia and how it is that we as academics are able to support our public health partners during this time. So with that said, I'll do my share screen, and I'll pause every now and then for questions, and I'm happy to take questions at the end as well. But I'm excited to sort of hear anything that you all have to ask. I'm happy to answer. So let me go ahead and share my screen. Okay, hopefully you all can see that now. All right. I just pulled this slide down from the Georgia Department of Public Health's website, the GDPH website. They've posted these metrics and graphics now for many months. And as an epidemiologist that has been combating the COVID-19 pandemic since the beginning, this is really two good graphs to see. The fact that our state over on the left, the vast majority of counties are not glaring red is awesome, because there was a period of time back in December and January when everything was red. And that is luckily not what we're experiencing now. The epidemiologic curve, as it's called on the right, really shows that the cases are dropping dramatically, which I think is something that is really important for us to see and to take a look at. You can tell kind of we're at a level of about where we were in September or so of 2020. And interpreting this graph is something that, again, I take a little bit of caution with, because we're not out of the woods yet. And we are doing a wonderful job with getting more vaccines into ARMS, but we'll talk a little bit more about that in a second in terms of vaccinations. But we are still, at a level that we were at heightened concern about back in August and September. We're not at the end of this pandemic yet, but we are definitely not as bad as we were in December and January, when we had the peak number of cases in deaths that we were seeing from this pandemic so far. So I will continue on from that, but that's kind of a snapshot of where we are now if you hadn't taken a look at these graphs in recent weeks. So now talking a little bit about the Emory COVID-19 Response Collaborative. Back in, let's see, about end of March, beginning of April, there was working inside of a school of public health at this time, and knowing that there was this thing called COVID-19, it wasn't looking good. There were a lot of us faculty who thought we need to do something. We want to do more. And we started brainstorming about how we could situate ourselves to allow our talents to be of better use, more practical use to our state and local public health department partners. And we brainstormed about how that would look, and we ended up with a wonderful funding opportunity from the Woodruff Foundation to be able to put that into action. And that's the manifestation of our Emory COVID-19 Response Collaborative. And it's really to do just that. As academics, we have a lot of skills that we can supply, whether that's research skills, mentorship skills, teaching and training, organizational skills, project management, and also, to reveal and uncover the fact that strong relationships with strong academic partners on the public health side can really do wonders in terms of improving and building and bolstering a response like this. Our ECRC leadership include myself as the director, and I'm supported by Dr. Jim Curran, who is our dean, and Dr. Kathleen Toomey, who is our state commissioner of health. And we discuss our plans periodically and make sure that we're sort of all on the same page with respect to how Rollins and Emory can really support Dr. Toomey's needs at the health department. Our 4 focus areas of our ECRC are on COVID-19 program planning, implementation, and coordination, just sort of what I mentioned about staying in sort of lockstep with Dr. Toomey about how we can most help her. Outbreak response and evaluation, which I'll talk about in a second, training and deployment, and COVID-19 surveillance, research, and monitoring. Talking a little bit about outbreak response, this is sort of boots on the ground type activities that are wonderful to get sort of real life experiences, especially for our students, in knowing what it's like to respond to a pandemic. Our outbreak response focus area is led by Dr. Jody Guest, who is our vice chair for epidemiology at the Rollins School of Public Health. And she has worked tirelessly since April of this past year to mobilize a cadre of really dedicated, talented, ambitious students to help her set up pop-up testing sites in hard to reach areas and hard to reach communities across Georgia. They've done a lot of different activities. Some of the pictures here are from some of their work in Milledgeville, and they've done a lot of work up in Hall County, Georgia, where there was pretty significant poultry plant outbreaks early on in the pandemic. Just to give you a sense of the breadth and the reach that she's been able to accomplish, since about April, May of last year, they've held 24 testing events and tested over 6,000 people. At those testing events, there's been a range of percent positivity. If you've heard that phrase before, it's the number of tests that you may have administered that come back positive. And that's one of the metrics that we use to sort of assess how the epidemic or the pandemic is going. You want to see that percent positivity coming down. And so her testing events have ranged from about 2% test positivity to all the way up to 32% test positivity. Some of the highest positivity rates have been in, like I mentioned before, those poultry plant outbreaks that were occurring up in the Gainesville area, where there was just large outbreaks among poultry plant workers that were working in close proximity to each other, and lots of transmission going on. Going back to some of her community outreach work in Hall County, in addition to the pop-up testing, they were able to coordinate with the local school system up there that was in the process of doing meal deliveries to families across their area, where they were able to join these school workers on the bus routes, and then be able to deliver age and literacy targeted public health messages to the parents and the kids that were coming to receive the meals. And that was really helpful outreach, as she described to me, because a lot of times the Hispanic community in that area was sort of missing a lot of the important public health messages at the beginning, just because of not accessing the same types of communication channels. Things weren't translated into Spanish readily. So she really capitalized on her relationships with the Hall County folks to be able to spread this type of information to the Hispanic community in a way that they could, that was accessible to them and they could understand. How this sort of dovetails again and can impact our students. These are two examples of students, MPH, Masters of Public Health students, who have been part of Dr. Guest's outbreak response team since the beginning. Lisa Chung on the left is using some of the data they've collected through their outbreak response team to do her thesis. Her thesis for epidemiology is on some of the work that she's doing with this outbreak response team. She also just applied to and was admitted to our doctoral program in epidemiology, so we're crossing our fingers that she'll stay with us. And Nellie Garlow on the right is one of my thesis advisees, and she actually took a different direction. And she said, you know what, I have had a wonderful experience with my outbreak response team activities, but I also want to get exposure to analyzing data from a different aspect of local public health. So she's working with me down at the Fulton County Board of Health to analyze some data that we had collected on a healthcare provider and interactions with men who have sex with men around promotion and uptake of pre-exposure prophylaxis, or PrEP, for HIV prevention. So she's working with me in a different capacity at the local level, just getting sort of a more well-rounded experience about what it's like to work in and around local public health. A little bit more on our local and state health department collaborations. This is a really interesting example of how this sort of pracademic mindset can really help our nation with respect to some, sharing of really impactful findings. So this is just a screenshot of a title of a paper that we were able to publish in the CDC's Morbidity and Mortality Weekly Report. That's a long phrase, it's a long title for a really sort of storied publication that is a wonderful way for lessons learned from a lot of different public health avenues to get out to other public health practitioners around the nation. And what we did with this paper, which was led by the first picture here, Carson Telford, he's actually a second-year Masters of Public Health student at Rollins that was working at the Fulton County Board of Health during this time. And he was doing a lot of the management of the long-term care facility outbreak data. And he said, why don't we take a look at the facilities who are doing the proactive and preemptive testing for COVID cases and comparing the size of the outbreaks that they have to the ones that only test after they discover a symptomatic COVID case. And so he led this analysis and was supported by the others of us on this paper. The second author here is actually a first-year epidemiology doctoral student who came from the Fulton County Board of Health. I worked closely with her there from 2017 on, and now she is pursuing a doctorate at Emory in epidemiology. The third image there is Dr. David Holland, who is the Chief Medical Officer for the Fulton County Board of Health. And the three of us at the end are the Emory faculty, those of us who sort of jumped in to say, let's help Fulton County, do things like this, because they oftentimes don't have the time to be able to push out really important lessons learned like this. So this is what we found. We found that among the facilities that did that early proactive preemptive testing before anyone showed symptoms, the outbreaks were relatively small. They were able to prevent so many cases, and only 2% of residents and 2% of staff ended up coming down with COVID in the 4 weeks following that initial screening. Compared to the facilities who tested after, one person showed symptoms, 42% of residents and 12% of staff ended up coming down with COVID. So it was really an interesting lesson that we were able to share more broadly. Now, another example, this is a familiar face to some of you. So another paper that we did with Fulton County was to try to look at, well, we knew we had a lot of missing data with respect to race and ethnicity. And early on in the pandemic, it was as much as about 45% of the COVID cases were lacking data on race and ethnicity. And that was because when you go to get a COVID test, the labs do collect information on you, your name, health insurance information, your address, things like that, but they weren't required to collect race or ethnicity information. So at the beginning of the pandemic, we lacked a lot of that data. And until about August, when there was a directive saying that labs really should collect that data at the time of testing. And that helped out health departments a lot with respect to those variables, being filled. Well, Katie Labgold, who is an ARCS scholar, she is a PhD student in our Department of Epidemiology, partnered with us down at the Fulton County Board of Health, as well as with our department chair, Dr. Tim Lash, and some others who are really familiar with the particular method that she was using for this paper, was to look at, well, what if we used other variables from people's tests, like their name, their address, things like that, to impute or do an educated guess at their race and ethnicity, so that we could really see with more clarity, perhaps, what the disparities were really like in COVID-19 outcomes, whether that was cases or hospitalizations or deaths. Are we really seeing the fullest picture possible if we have so much missing data, and what happens if we fill in the gaps? And so she published a very important, impactful paper that showed her results, saying that, yeah, we're missing a lot. And actually, African Americans are 1.3 times as likely to have been diagnosed with COVID than whites. And then Hispanics were 1.6 times as likely as whites to actually get diagnosed with COVID, which is not exactly what we were seeing with the actual data at that time. And so this is a great example of even a student at the doctoral level kind of entering this Pracademic space in this important time to contribute her skills, her knowledge to understanding this sort of COVID puzzle more effectively. And this paper was actually picked up by a PBS NPR affiliate outside of Pennsylvania, and did an interview with her, included her an article that they were writing about why race and ethnicity data is still missing nearly a year into the pandemic. And so that gave her a really good experience talking to the press, doing an interview. It's something that a lot of students don't necessarily get the experience doing, and she was able to do that. Now, just kind of talking a little bit more about racial disparities and moving on to vaccine uptake. You might have noticed that about 2 weeks ago, the Georgia Department of Public Health launched their new vaccine distribution dashboard. And I pulled this figure down from their dashboard today. So we've administered about 2 million vaccines, a little over 2 million vaccine doses here in Georgia. And that's fantastic in terms of just the history of vaccines and the rollout and the speed really with which we're able to do this. Now, what is still a little bit concerning and what we still have to work towards is vaccine equity. And if you look at the bars here, I know that the font is quite small, so forgive me for that, but you can see that this giant bar here is the number of vaccines that have been given to individuals of white race. A lot less have been given to Blacks and African Americans, and then also many fewer to Hispanics. And if you recall, I just said, there's been a lot of COVID cases and deaths among both Blacks and Hispanics relative to whites. So what is going on here? We did a survey as part of ECRC back in November, right after the election, but before the runoffs and before the election results, officially came in. So it was November 8th through early December. where we launched a survey of about 1,200 Georgians across the state and asked them questions about a variety of different COVID topics, but one of which was, when a vaccine becomes available for COVID, are you willing to get it? And 43% of whites said yes. Only 29% of African Americans said yes, and about 40% of Hispanics said yes. So that's from a background of vaccine promotion. Those aren't fabulous numbers. We would have loved to have seen many more people, especially at that time, be able to say, yeah, I'm going to get one. And where this is coming into play now is that we're still in that phase of vaccine rollout where demand is higher than the number of doses that we have available, which is fantastic. But when you look at numbers like this, the fear is that we're going to burn through those people pretty quickly with respect to the ones who want to get the vaccine. And so what are we going to do to continue to promote and encourage people who might be unsure or have questions to get the vaccine as well? So that is something that we're talking closely with the state about now, about how, what are the best ways to get the appropriate messaging out there, the appropriate encouragement from the appropriate messengers, because a lot of communities want to hear from certain people, respected people in their communities about, is the vaccine worth it for them? And so those are the types of things that we really have to pay a lot of attention to in Georgia due to the amount of vaccine uncertainty and hesitancy that we do have. A little bit more on sort of our efforts to address disparities. We're doing a lot of things to monitor, creatively educate, and collaborate. In the sort of the left-hand side about monitoring, one of my colleagues who works in the Global Health Department, Shivani Patel, also has created a dashboard. And she did this early on in the pandemic, and it's her COVID-19 Health Equity Dashboard, where she's really getting pretty granular with the data that she has access to show, what does testing look like in a certain county, for instance? What is the breakdown of by race of people who are getting access to testing? She's now pivoting to try to integrate vaccine information into her dashboard. And she has a wonderful podcast right now that was, I think, recorded just last week on NPR's podcast called Did You Wash Your Hands? Where she talks about this relationship between vaccine equity and vaccine effectiveness, and how being more equitable with our vaccine distribution will really impact our vaccine effectiveness overall. Then in the middle, I'm working with, again, Dr. Jody Guest, who's the middle picture on this sort of educate slide right here, as well as one of my colleagues in the epidemiology division, Dr. Lauren McCullough, to host sort of more intimate sessions with various audiences, one of whom we just launched with our students last Monday, a week ago today, with kind of a educational but sort of informational tutorial about how to talk about the vaccine more effectively with your peers or your friends and your family or your grandparents or things like that, so that they can understand what they need to know to make an educated, decision about getting a vaccine. And so this was a really fun session that we led, where we actually did a talk. We sort of had Jody give a talk that she typically gives to audiences about the COVID-19 vaccine. And then we dissected it for the students and told them, now, did you notice her tone here? Did you notice she used a really useful analogy here? Do you see how she, switched to talking very seriously to, talking a little bit more lightly, and gave an experience that she had when she got the COVID-19 vaccine? So things like that I think were really useful practical tips for our students to be able to take back and become sort of more confident conduits really of this information themselves. And then lastly, collaborating with DPH. Like I mentioned, we are constantly meeting with DPH and Dr. Toomey to make sure that, we're in lockstep with her and kind of working to promote her ability to get information out to residents of Georgia and to improve testing, improve vaccination. So that is something that we're always working towards and improving. The last piece that I really wanted to focus on today is on training and deployment in a particular program that we launched as part of the ECRC. I want to start with you with a little bit of background about the U.S. public health workforce prior to COVID-19. And there was a survey that was done by a foundation called the de Beaumont Foundation back in 2017 that was done, I think, among about 40,000 public health workers in the United States across all 50 states to try to ask questions about their job satisfaction and their credentials and their experiences and how long they've been in their placements and things like that to get a sense of where we are with the workforce. And here are some interesting sort of slides that they have up about their data. They found that 42% are over the age of 50. 33% have advanced degrees, meaning a master's degree or a doctoral degree. Only 14% have a public health degree, and about 42% have 5 years or less of work in their particular agency. And so all this said is that, there is a need to reinvest in, even prior to the pandemic, there was a need to reinvest and reinvigorate our public health workforce with folks who, have degrees in public health and want to stay and work in the state and local health department system. When asked about their reasons, for considering leaving in the same survey, for those that were under 33 years of age, you can see that the top reasons here for considering leaving. Pay. There's other places to make a lot more money than state or local public health. So pay has always been at the top of the list. But there's other things here that are right underneath that really have maybe a potential for change and being able to affect change in these more readily. Those include lack of opportunities for advancement, job satisfaction, work environment, lack of acknowledgement and recognition and support. So, we're thinking, in the pandemic hit and kind of how can we bolster how can academics or academia bolster the, public health workforce? There's a lot of things that we can do here to impart either our knowledge or our assistance to help improve some of these metrics. Fast forward to 2020, COVID-19, came up. Public health departments knew, much would fall on their shoulders. I don't have this number off the top of my head, but the average number of epidemiologists in a local health department in Georgia, working in Fulton County at the outset of the pandemic, there were only 4 epidemiologists in the epidemiology division at the outset of the pandemic. And Fulton County is one of the largest health districts in the state. So that should give you a little bit of perspective about the need as we were entering into the pandemic. So, how can we help? And going back to what I said before, we attract, we teach, we mentor, we do research. And so when we were thinking about the ways in which we could help, this idea came to me in April saying, like, why can't we develop some type of program to not only recruit and place, early career epidemiologists, at least inside of our local health departments in Georgia, but how can we do it in such a way where we can continue to support them? And so that's where the idea of the Rollins COVID-19 Epi Fellowship Program came in. And what we have done with this is put out a solicitation, hire and place talented junior level epidemiologists in each of our state's health districts and at the Georgia Department of Public Health, and foster their success by providing them resources on career development, management skills, and kind of instilling in them from early in their career this sort of knowledge that building academic public health partnerships can really be beneficial for state and local health departments. And just so you know, our Georgia is divided up into 18 health districts for the purpose of managing public health. Some health districts are a 1-county health district, like Fulton or DeKalb, for instance, just because it's done mainly by population size. So we have such, large populations in Metro Atlanta that our Metro Atlanta districts are, 1 county, 2 county, 3 county health districts. When you get outside of Metro Atlanta, some of the health districts will cover 8, 10, 12 counties. And so that's very different. And there's very different needs of those populations, both inside and outside Metro Atlanta. The uniqueness of our program, because there's other fellowship programs like this that are operating across the country, but ours is focused only on Georgia. And it's novel in its connectedness to a top-tier school of public health. There's a couple other fellowships that do this, that are run either by a professional organization or by a state health department. Florida, for instance, and California have similar programs. but they're run out of the health department. And what does it look like when you run it out of a top tier school of public health? Well, that enables them to have benefits as Emory hires, which include things like healthcare benefits, but also being able to access our Emory library system, or the unique sort of seminars and trainings that come across my inbox also come across theirs. That we can leverage our academic support for the fellows, and that, again, we sort of work to expand our public health partnerships across the entire state, not just in Metro Atlanta. And so the vast majority of our fellows' time is spent as a practicing epidemiologist. 90%, we want them to spend 90% of their time doing epidemiology and working with their local health department partners to affect change in their communities. The other 10% is provided by us with mentorship, doing special curriculum, which I'll talk about in a second. But the academic mentorship part is really the the aspect of our program that sets it apart from other similar programs that just have the site-based mentorship. This is the map of our inaugural cohort, which I think is just so fun to show. It is a diversity of genders, races, ethnicities. It is wonderful to see this type of diversity with this inaugural cohort. And they're working with them are just wonderful. We have 17 fellows, 15 across the districts and 2 at the Georgia Department of Public Health. And just to give you sort of a little bit of glimpse into one particular fellow, this is Aaron Muirhead. He is our fellow in the Gwinnett Newton Rockdale District 3-4. And he is a graduate of Georgia State University. He was a Fulbright scholar before coming to our program. He did work on Zika virus disease in Brazil. He grew up in Gwinnett, and talking with him, this is a terrible picture of me. This occurred on a Monday morning before I even had any time to put on makeup, but it was a mentorship session that I was having, and he could do it at that time. But he is passionate about making a difference in the place where he grew up. And he's very ambitious, and he's also very observant on leadership. And that's something we spent a lot of this conversation talking about. What he's done as a fellow so far, in his first month on the job, he did a flu vaccination outreach event with the Rockdale County Jail. He is the district's business sector liaison for outbreaks that occur in the business sector. And he is working closely with the team that investigates daycare outbreaks as well. More importantly, or as importantly, is what his supervisor is saying of him. Saying he has been an exceptional and set a precedent for what should be expected from a fellow. He's passionate, he's invested, he's developing a keen understanding of that delicate balance between politics and communication and outbreak investigations, and is taking a lead in working with community groups that have the most need and the most questions. That is a wonderful type of thing to hear back from a site supervisor. Just quickly, here are some of the other things that some of our other fellows are doing. Umair in District 9-2 in Waycross, doing data entry on new COVID cases, communicating with schools and nursing homes. Donovan Stevens in District 4 delivered vaccine information through a Q&A style Facebook Live session with community members in his area of LaGrange. Victoria Roy up in District 1-2 in North Georgia, again, doing things related to maintaining and updating daily vaccination information from the counties in her district. And then, again, Mallory Hazel here in Fulton County, who I work closely with, she is from Fulton as well. So she's really excited to be able to be working in her home district, doing analysis, weekly analysis of our COVID-19 case data and updating Fulton County's biweekly epi reports that go up on the Fulton County Board of Health website. Zena Belay here. This is a picture of Zena, my right-hand woman when it comes to managing this fellowship program. She's our director of the fellowship. But these are just the type of events that we're trying to schedule for and with our fellows. In January, we enabled them to have a conversation with Dr. Walt Ornstein, who some of you all may know. He is part of our Emory Vaccine Center and is one of the most renowned faculty and experts in the nation on vaccine safety and hesitancy. So they got to have a one-on-one conversation with just him and be able to ask him questions about how they can better overcome, vaccine hesitancy in their areas. They're working on their competency achievement plans right now as fellows and working through what are the projects and activities that are going to align with the core competencies we want them to come out of this fellowship program with. And then doing strengths training to sort of understand how they can bring their personal best to the workplace and leverage that for being able to get the most out of their job. And then coming up in a few days, we have a bioethics and cultural competency training with an expert from the Tuskegee University. Briefly, we have a second fellows cohort coming up that we're soliciting for right now, and the applications are due this Friday. We're hoping to have this second cohort in place by June of this year. I just wanted to end with sort of, and I'm happy to take questions after this too, but sort of just thoughts on the needs for public health in Georgia. Going back to sort of public health and in a time of crisis just really depends a lot on the talent and the sort of the quality of people that we have working in our local and state health departments. And this is kind of true nationally. We were able to get funding for rapid hires of contact tracers and case investigators, and that's fantastic. During a surge, that is wonderful. That is really a need that is useful. But thinking longer term about getting to the point where we're a lot even lower on that epi curve that I showed you at the beginning, really investing in people who have an interest and a desire to stay and work in that local health department space, I think is just sort of second to none with respect to our ability to improve our public health workforce in Georgia. The Fellows Program, I think, is a good start with that, and I hope it continues into the future, even after COVID-19, but also some of this Pracademic doctoral and faculty support to enable people like Katie Labgold who have an interest in diving in, or folks like me who have an interest in kind of straddling academia and public health practice to try to put our research hats into the service of the local health departments. I think that that's something that we could grow a lot in Georgia, not only at Emory, but also, Georgia State, Morehouse, others across the state. And then upgraded IT systems. We've learned a lot about how much data comes in from tests, from vaccines, from people wanting to register as volunteers, and how to have all the IT infrastructure behind that so that we can get the answers we want or the people placed where we want them quickly and the background checks run and things like that. Our IT systems in Georgia were created around about 15, 20 years ago. And in an IT world, that's those are ancient. IT systems get upgraded, on the daily, it almost seems. And so this is one area where I think Dr. Toomey has really gotten a lot of support for from the state, actually, in terms of being able to support and build out our systems here in Georgia. So that's wonderful. But I'll go ahead and end there. That's sort of a snapshot of the types of things we're doing with the Emory COVID-19 Response Collaborative. And I am more than happy to stop screen sharing and answer questions.
Thank you, Dr. Chamberlain. I will get things started off with a question of my own, and then maybe some of you will have some as well. Have you seen scholars like Katie Labgold adapt their research to address the needs of the pandemic? And if they have, does that change the timeline for getting their PhD?
That's a great question. Yes, I have seen, especially the doctoral students, shift gears, and it's not been easy for some of them, but but they've had to do it, especially students who were focusing their dissertations on international work, international research studies. A lot of them got very much slowed or even stopped because travel wasn't happening. They couldn't go over and do specimen collections or interviews like they had planned. And so I have seen a number of doctoral students need to pivot. And we have been as supportive as possible to, for instance, opening up avenues in the local health department, for instance, for saying, okay, we come to us now, like that we can help you rework your dissertation aims, for instance, so that they can meet some of these, meet your requirements, but also, be responsive to how research minds can help assist with the pandemic. One student in particular that I'm thinking about is an MD PhD student. She had won an NIH funded award to do tuberculosis research overseas, which got canceled. And she was able to come into the fold at Fulton County and is getting at least one of her dissertation aims out of some of the work that we're doing in Fulton County. So yes, it is very much impacting doctoral students, especially. Master students are a little bit easier to sort of plug in to places because their trajectories just aren't quite as long-term. They're only 1 year, whereas doctoral students have multiple years of research. And so it is, we're doing a lot, I think, in the epi department, especially to try to support those students whose dissertations were really, turned around or turned upside down because of the pandemic. Good question.
I have a question.
Sure.
Do health departments have a choice of what kind of vaccine they get? Who decides what health department gets which vaccine, and how do you think the release of the J&J vaccine will affect the vaccination rates?
That's a great question. Those decisions about, the vaccine comes into the state health department has the sort of, they're the recipients of these vaccines, and then they will, divvy out to the vaccine providers, whether that's local health departments or they're, more and more coming into the private sector with respect to giving vaccine doses to general practitioners or things like that to be able to enable them to. Now, I am not entirely clear on the sort of the exact mechanisms of, do they know how many doses of Pfizer are coming versus Moderna and who gets what? Now, certain vaccines, have different requirements with respect to storage. So depending on, maybe a local health district will say, we're still working through our Pfizer stores, or that our freezers are still full or they're empty. So if we can accommodate more that need that low, that low, super low freezing point. So it's to date, it's just been, as the vaccines have come in, trying to go ahead and get them out as quickly as possible. And I don't know that there's any sort of meaningful, insights into which health departments are getting what vaccine. I don't think that they have a lot of say in that. I think this is kind of like what's delivered to the state gets pushed out as quickly as possible. I think the J&J vaccine is going to be great. I think any more vaccines we can get into the pipeline are fantastic. And I think that it's going to help a lot with respect to coverage, especially because we only need one dose of the J&J vaccine, which I think is wonderful. So from the initial efficacy data, it shows to be a little bit less efficacious than the other first two, but, still having an efficacy of, 60, 70%, that's still fantastic in terms of, if you think about the provision of vaccine at a population level, it will still contribute a lot to reaching herd immunity as, more quickly. So I think it's just going to be another great addition to the armament of vaccines that we have.
Allison, I don't know if you can touch on this or not, but Patrick and Aaron's study that shows the real prevalence, is that something we can discuss? This is a study that's coming out. I'm just not sure if we can release data here, but Allison can tell you what it's about. And I think it's going to make, to me, it's exciting news because it's going to say a lot about herd immunity.
Yeah, so, so two of our investigators, Patrick Sullivan and Aaron Siegler, they did what was called the COVID View study, and they got money from the National Institutes of Health to do a nationwide household sample of households across the country. The Woodruff Foundation offered us funding to do an oversample of Georgia households to get a statewide estimate of COVID-19 prevalence in Georgia, and then the national survey, so nationally. And that entailed sending out COVID-19 saliva kits, antibody tests to random households, and to try to sort of see how much COVID has happened. And so their data is just coming in, it just came in now. And Catherine, I am not sure if we are able to say that yet. We're having a meeting later today with the state to talk with them about that. But it's, the bottom line is that, it's not a surprise that, we were only able to see the tip of the iceberg with respect to cases that actually go to get tests, right? So like the data that we have traditionally worked from are people who go and get tests. Somehow they get tested, whether they are symptomatic and they show up to get tests, or they're asymptomatic, or they're concerned that they were exposed and they get tested. That truly is only the tip of the iceberg with respect to actual infections and how many people have been infected. And so we're looking, it's going to be, there's a lot more people who have probably had this disease than we've seen so far. And that has impacts on, how herd immunity has played out, because there is some, protection that you do get from natural infection. The question is how long it lasts, and we just aren't far enough in the pandemic to know exactly how long your natural immunity lasts from a natural infection, if that varies by the severity of disease that you had. So if you had a really bad course of COVID, do you have more and stronger antibodies than if someone just was asymptomatic? So a lot of that research is being done right now, but I think that, if you look at the epidemiologic curve, I think that, a lot of that infection that we have had is indeed playing a role in addition to how many people we've now gotten vaccinated. So we see that curve coming down. But it's what is, and I think it's great to some extent. We've had a lot of mortality because of that. That's why sort of natural infection isn't as safe as vaccine-induced infection, because you don't know what your course of illness is going to be like. You don't know if you're going to be one of the people who's going to get through it and skate through it fine, or if you're going to have to be hospitalized and risk going into the ICU, or even worse. And so that's where we have a little bit control over the outcomes with respect to having sort of these safe vaccines that we were able to study in trials. But I think that, there's a lot more people who have been infected than we are able to see on, the DPH's dashboard, for instance.
I was going to ask another question along the same lines. We look at deaths, cases, infections, we look at hospitalization and deaths, but do we look at the severity of the disease at all along the way? Do we track that?
Yeah, we do. And that's where a lot of our, if you've noticed sort of a lot of the trials with respect to new and different medications and trying to understand their efficacy with trying to reduce, curb really severe illness. But, one of the things that a lot of Emory investigators are sort of honing in on now is trying to study the long haulers, the people who have had bad, long-lasting side effects of COVID-19 infection, and understanding why that happens. And is that getting at your question?
Yes, that was very good. Because I've always thought our testing is a little skewed, because the only people that go to get tested are people who think they have the disease or might have it, as opposed to just the general population.
So that's so Lisa, let me just point you out. When you look at that epidemiologic curve and you think about humans and you think about what we did prior to the holidays, I think that the best thing to sort of get to your point about sort of this selection bias that you're referring to by people just showing up to, thinking that they're sick or they have symptoms and, coming up positive. What's really interesting to think about is a lot of folks were seeking out testing right before the holidays because a lot of people wanted to get the all clear, right? To try to see their families, well-intentioned people wanting to do the right thing, really wanting to be together at the holidays and going to get tested. And I think what's really interesting to think about is because of that phenomenon that was happening right before the holidays, we probably had the best of all time periods in the pandemic, the best sort of understanding, the least biased understanding of how much COVID we were seeing in the community right before Christmas and New Year's, because that was a lot of people were going to get tested regardless of whether they were symptomatic or asymptomatic or their job was telling them they needed to do that. So that was at the height of testing, and that really gives you a glimpse into, okay, a lot of people had COVID or were being detected with COVID, even when likely they weren't symptomatic.
So Allison, I have one more question for you. Y'all heard Allison's amazing background, and we would all wish that Allison had been an ARCS scholar too, because we would certainly love to claim her as an ARCS scholar. Allison was actually a Livingston scholar, and at Rollins, that means that her department chose her as the most outstanding PhD student for the years that she was a Livingston Scholar. So my question though is, I know that meant a lot to you to have funding. I wonder if you might just comment on the importance of helping PhD students, because that's what we're all about, is trying to provide additional funding for outstanding PhD students. So you can speak to the need for that personally.
I can. I was thrilled when I found out I got the Livingston Fellowship the Livingston Scholarship, because at that time, my laptop had just crashed. So it gave me the freedom to be able to purchase another laptop, which was fantastic. I will say that I had a conversation with Katie Labgold recently. And what she told me, which some of you may know, the ARCS scholar that I featured in my slide deck, is that she was able to use some of her funding to set up a workstation at her house because Emory shut down. They locked the doors. You couldn't go in. So she was able to purchase a suitable desk and a chair for her workstation at home to be able to continue to work on her dissertation during the lockdown and even still to this day. But why that's important to share is because Katie, her desk is right outside of my office at Rollins. And honest to God, Katie Labgold was there at 8:30 a.m. every day. She did all of her work at Rollins. She was there Monday through Friday. So I know for a fact that money went to good use for Katie, because she was never working from home before the pandemic. So her ability to have that flexibility and freedom to be able to set up a workstation at home, I think was more important for her than any other doctor. I mean, she was there literally every day. And so that is really nice. And I also think it's nice to be able to, have someone or an entity recognize your hard work as a doctoral student, and to be able to say, I think you have promise and I really would love to see you flourish. And here's a little bit extra to make sure that can happen for you. And I think that was a really nice, feeling to have as a doctoral student, and to be able to live up to it as well. And knowing that you want to do your best because someone else is wanting you to do your best.
That was the perfect question, Catherine, for us to end. Dr. Chamberlain, thank you so much for your time. This has been a wonderful afternoon for all of us.
Well, thank you so much.
Thank you, ARCS members, everyone. I hope we'll all get together soon.
It's great to see y'all all. Thank you.
Thank you all.
Thank you, Catherine. Thank you, Dr. Chamberlain.